Welcome to POTUS 2017, where we keep watch on the Oval Office and pour cold hard facts on the overheated political rhetoric. I'm Marty Goldenson, in for Brian Lehrer. Today, the human cost of Trump care, from a doctor who believes the best treatment plan must now include a high dose of political protest, and from another doctor who sees a high price for women if the act passes. And later on in our evidence-based politics segment, Planet Fever, how higher temperatures from climate increase the global death rate. First, the Better Care Reconciliation Act. The GOP is reportedly trying to rewrite it in a hurry to get a better score from the General Accounting Office and by Friday, bring it to a vote. This before the holidays. The current version, which needs about 9 more solid GOP supporters, would leave 22 million uninsured in 10 years, 2/3 of them low-income people on Medicaid. It would cut health care spending nearly $1/3 trillion. These are not just numbers to our guests. Dr. Danielle Ofri, internist at New York's Bellevue Hospital, an essayist, and author of a shelf of books including What Doctors Feel, How Emotions Affect the Practice of Medicine. And with a special focus on women's health, via Skype from Baltimore, Dr. Diane Horvath-Cosper, an OBGYN and advocacy fellow at Physicians for Reproductive Health. Welcome to both of you.
Thank you.
So
Thank you.
This is not, and let me start with you, Dr. Ofri, this is not a bill you want to see passed. What worries you most and concerns you most about it as a physician?
Well, when I see my patients, my most important priority is that they get the care they need. So if their medication, for example, is not covered by their insurance company, then I have to get on the phone with the insurance company and argue with them. And so now I worry if they lose their health insurance, they lose their coverage, they won't be able to get medical care. And I really fear that some will die, particularly the fragile, very ill patients don't have much wiggle room if it comes to losing their medical care.
This role of the doctor as advocate isn't really new. You're always calling insurance companies or trying to get the right medicines. It's not so much just diagnosis and you should take this pill. You're advocating all the time now, right?
That's half of our job. I mean, when the patient leaves the room, then there's making sure the medications get to the right pharmacy, getting the appointment with the cardiologist, making sure the echocardiogram is scheduled. All these things are part of your job. And so it dawned on me, if my patients lose their insurance, I have to get on the phone with the senators and make sure that doesn't happen.
Now, you may be happy to call up a senator, but most doctors aren't. They'll call an insurance company, but they make a distinction there. But you think there's maybe no moral distinction?
I never called a senator before this year, I have to say, because part of me thinks that politics doesn't belong in the exam room, and I want the exam room to be as non-judgmental as possible. But when it dawned on me, for example, if there was a new medication that had a toxic side effect, we'd be sounding the alarm. And so if I think this bill will have the same toxic effect on my patients, I have to do the same thing. It's really no different at this point.
It's the public world invading what you would like to see as a very private space.
The space is still private because I don't discuss politics with my patients in the room, but when they leave the room and I worry that they'll lose their care, then I have to continue that advocacy outside the exam room.
Now let's turn to our other doctor for a moment. You've been doing advocacy for a long time. This is not a shift for you, is it?
No, we, especially in reproductive health care, we've needed to be advocates because our patients have been under attack by legislators, both nationally and at state levels, for a long time.
Right. When you say our patients, you mean OBGYN doctors?
I think OBGYN and specifically people who are looking to access contraception and abortion care.
Right. What will this bill mean for women, and how many?
Well, so I think Dr. Ofri noted that a lot of people will lose their insurance, and you really can look back to what life was like before the Affordable Care Act to see what might happen. 8 in 10 private plans before the Affordable Care Act didn't even cover maternity care. And that's something that now is an essential health benefit and covered under the Affordable Care Act.
Right. And Medicaid covers, what, more than half the births in this country, no?
It's almost 50%, yes.
What happened to you when you decided to be an activist and speak out regularly in your position, which is choice? What happened at your hospital? They muzzled you, right?
Yes, so I wrote an op-ed that was picked up by the Washington Post after I had the disturbing experience of seeing my daughter's picture on an anti-abortion website that was designed to basically intimidate me out of practice. And then after writing about it, I got some coverage in other media, and my hospital told me I was no longer allowed to speak about abortion publicly.
And so what'd you do about it?
So I was terrified I would lose my job. And so I talked with some advocates, some attorneys, and physicians for reproductive health, and was able to file a complaint with the Office for Civil Rights under the Department of Health and Human Services.
Right, that's a little bit of ironic use of what had been something to protect people who were anti-abortion, no?
Right, it had never been used to protect the conscience rights of people who feel morally compelled to provide abortion care.
Right. Now, you seem to have no fear about starting, I guess you would call it, a kind of project called House Calls. What's House Calls?
Well, when I published an op-ed in the New York Times last week encouraging individual doctors and nurses to call their senators. The editor chose the title, A Doctor's March on Washington, and I got all these emails saying, so when's the march? So
you meant a virtual march.
I didn't mean any march at all, but that's what they chose.
I see.
So Catherine Stratton, a filmmaker, and her colleagues at the Resistance Media Collective and I joined forces to make the House Calls campaign, because I think that traditionally doctors have made house calls. Now it's time to make virtual house calls to our Senate and our House as well, to let them know how our patients will be affected by this legislation.
You figured that it would be, I mean, it's one thing, the AMA has come out actually against this. And
all medical groups have.
Yeah, quite strongly, saying I think one of the vice presidents there didn't want to have to say to his patients, oh, you haven't had coverage for 63 days, you'll have to wait 6 months to get care from me, even though you have stage 4 cancer. That's almost an exact quote from him. Yet that's an organization. You feel that there's some power in individual doctors doing this. Why?
Well, when I call my senator, I tell them about individual patients. I had a woman in her 50s who lost her job and lost her care, and she couldn't afford insurance, and so she let her diabetes and hypertension go untreated for almost 6 months. And by the time she came to me, she was much sicker. And that will happen again to many of my individual patients. I have people in mind who have cancer, who have heart disease, who need contraception, who will not get the care, and I can see what will happen.
Right. This, I think, is a lesson in what they call narrative medicine, where you tell me narrative stories about what will happen. Let me turn back to you for a minute and ask you about what will happen between the OBGYN and either a mom who already has 3 kids or a teenager who doesn't want to be pregnant. Well, how does this change things?
Well, so I think that putting people off their insurance, which this bill will most certainly do, means that people don't get routine preventive health care. And in the world of OBGYN, that can mean, in particular, cancer screenings like the Pap test. And I think about a patient that I saw before the Affordable Care Act who would have been covered under the Medicaid expansion. And she was diagnosed with cervical cancer at a very late stage, and ultimately, after undergoing radiation and chemotherapy, died, leaving 3 small children. And she would have literally had her life saved if she had been able to get routine preventive health care that she would have qualified for under the Medicaid expansion.
Also, Dr. Horvath-Cosper, or can I call you Diane?
Diane's just fine.
Thank you. Do you happen to be familiar with what this bill, if unchanged, would do to Planned Parenthood?
Yes, so this bill, just like the House bill, calls for a 1-year period where people will not be able to use their Medicaid insurance to obtain services at Planned Parenthood as they are now. And that definitely means that there will be communities that don't have the capacity to see those patients elsewhere.
Yeah, it's sort of interesting. It was, this little piece of legislation was designed precisely to rule out Planned Parenthood, wasn't it? It said,
Seems like it was.
Yeah, if you get more than $300 and something million worth of reimbursement, no one else fit that bill exactly. Yeah, it's interesting because Planned Parenthood would argue, I think this is right, that we're not using the money for abortions. Their federal money is, I think, 40% of their budget. And just like many hospitals that avoid this problem of not having the federal government pay for abortions, which has been illegal since 1976, they use other monies. So is this right?
Correct, and because many health institutions will close, some Planned Parenthoods, rural hospitals. I mean, for many people, there won't be places to get their medical care. And then what happens? What happens if you're getting dialysis, you're on chemotherapy, you have congestive heart failure? What do you do if your hospital closes or your Planned Parenthood clinic closes? People don't get their vaccinations. So I don't understand what the centers are thinking, because they've never been in an exam room. They've never sat with a patient and told them about a terminal diagnosis or a new cancer, new diabetes, and then to say, okay, well, sorry, no more insurance, you can't get treated. What do we do as a society? Do we just let people die in the street? Is that the plan?
It's interesting. Maybe it is the plan, or maybe the plan is people did what they did before the Affordable Health Act, et cetera, and which is walked into the emergency room. But that's expensive, right?
And it's a terrible way to give care. It's not set up to give preventative care, screening, to prevent people ending up in the ICU. The whole goal of preventative care is to prevent people from getting very sick. And so it's a terrible way to give care.
I think all the studies show, do they not, that people who have regular care have fewer emergencies and end up spending less money.
Right, and our goal is to keep patients healthy. And so we want to get their diseases before they explode. I had a patient who ran out of his insulin, and he didn't know how to get a refill. And so he waited until his appointment 3 months without treatment. And in those 3 months, his diabetes went completely out of control. And so I can see for patients like that, any disruption will be a disaster and could really be deadly.
Does it surprise you that the Health and Human Services Secretary, who is a doctor, hasn't experienced what you just said, that intimate moment where you have to talk to a patient about their future, maybe even about their death?
It baffles me. I mean, there are several physicians in the Senate, and Dr. Cassidy, Dr. Paul, and they took a Hippocratic oath to do no harm. And how can they countenance letting patients go without care? Is that what we do as caregivers? I don't even know what to say, to be honest. That's what we do.
Yeah, you don't know what to make of it. Diane, do you know what to make of it? When you see doctors in the Senate and other doctors who seemed, at least to me, more concerned about the bottom line than the immediate health of their patients.
I went into medicine to be with those people in the exam rooms and to provide that care. And I'm also baffled by politicians who claim to value life and want to protect families and, values, going and turning around and taking health insurance away from 22 million people. What do they think is going to happen? I think it's pretty disingenuous.
What changes in this bill would please either of you enough to say, all right, this is okay that this has passed? What should be changed? Is there anything in there that you think is worth reforming or leaving in there as a reform to Obamacare?
There's lots that could be done to reform Obamacare, but I think we have to start with the sort of ethical ground point that we want our citizens, our people, to get treated for their medical conditions. So we shouldn't be cutting people off the insurance roll.
But this is the philosophical difference. You believe in universal care.
Well, the same way if you call 911 for a fire, you get the fire trucks no matter who you are. And it should be the same for medical care. No one should have to be, you didn't pay your fire bill, sorry, we're not going to put out that fire.
That actually happened for a while there in one area in Florida.
Right, and then we changed it because it was untenable. And also because...
Not just because it burned down the neighborhood, otherwise...
Well, but you know what? If your neighbors don't get their medical care, they'll end up in ER and those will be your taxes paying for it. So it does affect us. Plus, we have families, and if you yourself are healthy, but you have elderly parents or a sick child or a relative you're caring for, so we can't escape it. So I think that the idea that we're one community. So I would say if we reform healthcare, we want to have the idea that everyone can have healthcare, and whether it's single payer or the private system, we can still work in a framework. And I think many of the physicians who opposed the Affordable Care Act, it wasn't on ethical grounds; it was on financial grounds. And that's a reasonable thing. You can work to improve that. But the opposition now to the current legislation is on moral grounds and ethical grounds, that it's allowing people to die, to not get care. And that's a different story than whether the payment structure could be improved.
What would either of you change about Obamacare? Let's say there was an actual rather than a war between Republicans and Democrats, what if they got together and said, okay, this is an imperfect system, and we're going to work together to improve Obamacare and strip out the stuff that's not working, bolster it here and there, and change also what maybe the doctor experiences in the privacy of her room. Name a change or two you'd like to see?
Well, one thing I think that didn't work with Obamacare is that premiums went up for a lot of people, but not because so much of the legislation, but because there were many fewer insurance companies. And I think for the rates to go down, you need to increase the number of companies that are in there. And so having, for example, a public option to compete with private companies would actually bring down the rates, because if the federal government with its large size can negotiate drug prices and procedure prices, it could bring it down. So that's one thing I could say.
Diane, any thoughts about how you might change Obamacare if we were in this world of an actual discussion rather than a kind of political war?
I think that more could be done to combat some of the redundancy and waste in the system. I mean, we know that Medicare and Medicaid run with lower overhead than a lot of private insurance plans. So whether that means putting people on a program like Medicaid or Medicare and having more people on that program and run it more efficiently, or if it means addressing things like some of the redundancies in the electronic medical record, I think those are good places to start.
Thank you, both of you, for sitting with us. Stick around, because I want you to be part of segment 2 of POTUS 2017, where we're going to talk about another medical crisis, global warming and heat, when we bring in some additional evidence. Time for evidence-based politics, where we pour cold hard facts on the overheated political rhetoric. 2016, the election year when candidate Trump was calling climate change a hoax, was the hottest year on record. And 2017 is seeing dangerous heat waves. A record one scorched the Southwest last week with 3 straight 115-degree days in Tucson. In Las Vegas, it exceeded 110 degrees for more than a week, at one point reaching 117 degrees. Humans do not do well in such temperatures, especially the elderly. In San Jose, California, a couple of heat fatalities were reported when it hit 103. And heat can kill in big numbers. Back in 2003, a European heat wave killed approximately 70,000 people. Moscow, 10,000 in 2010. Chicago, 700 in 1995. A new study finds that about a third of the world's population experiences deadly heat, but that could rise to half the world's population by the end of the century if greenhouse gases aren't drastically reduced. To explain this research, we are joined via Skype by Camilo Mora, ecologist and professor at the University of Hawaii at Manoa. His study, published in Nature Climate Change, is called Global Risk of Deadly Heat. Welcome to POTUS 2017. Thanks for coming on.
Thank you, Marty, for having me.
So tell me, how did you do this study? What'd you look at?
So one of the things that we did for this study was to look at cases of heat waves around the world where people had died. We took the climatic conditions on those places to find out why is that people die, and we found these very unique conditions of temperature and humidity that if they are exceeded, people die. And one of the things that was mind-blowing of that study is the fact that we found close to 2,000 cases when people die because it got to be too hot since 1980. So people keep criticizing climate change because this is something that is going to happen in the future. One of the things that we identified with this paper is that this is already happening. As you point out, those few cases are very common, but close to 2,000 cases had been reported in the literature since 1980 when people just died because it got to be too hot.
Our Dr. Ofri from our previous segment is here, so I'm going to turn to her for 1 second and ask her why people die when they get too hot. Why does an old person die if they don't have an air conditioner and it's 110 degrees somewhere?
Well, typically they die of dehydration. People aren't drinking enough fluid to replace the fluid losses from sweating, from overheating, and often it's the very frail who are more susceptible. So elderly, patients with, bad kidney function, bad heart function, diabetics, young children, those who may be somewhat impaired and can't access water are the ones who are most susceptible to dehydration and overheating.
And you found, Mr. Mora, that there was a kind of a gradient of humidity and temperature, which created a kind of area in which it became dangerous and defined those areas, right?
So one of the things that happens, as Dr. Danielle points out there, is the fact that there are these conditions that prevent the body of expelling the heat that it generates, right? Unfortunately, the mechanism that we had to expel that heat is through the sweating, through the evaporation of our sweating, right? So it turns out that places that are very humid, that sweat doesn't evaporate. So heat waves, when it comes down to heat waves and the danger that they put on humanity, is not only the temperature, it's pretty bad, the temperature, but of course what we found is that when you combine that with high humidities, that's just a recipe for disaster, because it's not only hot, but it's pretty humid, and then the body cannot expel that heat. And unfortunately, there are all kinds of physiological responses that happen that make a person die, as the doctor just mentioned.
We're going to put up on the screen a sort of scary looking graphic that you guys have generated with, here it is, with a bunch of two gradients of both temperature and humidity, and these little black crosses and some what look like almost flames on the upper left. Can you, and it's got the blue line and the red line, and it has the word deadly with an arrow to the right. Can you explain what this research shows?
So this is a plot between temperature and humidity, and the crosses point out the close to 1,000 cases that we found that we can get the actual climatic conditions on those places. So those crosses there identify the conditions of temperature and humidity since 1980, when people just die. That red line, what we found there is that in all of the cases that we investigated, if you are to the deadly side of that line, people had died. Today, we identified that 30% of the world's human population, at least during 20 days a year, are on that side of that threshold. We are talking conditions that have killed people before, and 30% of the world's human population exposed to conditions in which people had died already.
And you believe that global warming will make this more of a problem. Are there other factors?
Well, climate change, unfortunately, we are talking about heat here, right? So it's pretty bad already, and we already know that we are going to heat up the planet by about 2 degrees more if we do the best we can, right? So obviously, you add more heat to these conditions, this situation is going to get bad. And fixing climate change will make this thing bad, in the sense that it's already 30% of the population. If you heat up the planet by 2 degrees more, it's going to be 50%. But if you don't do anything, it's going to be 75%. What I'm talking about here is that our impact in the planet has been so massive that we run out of good choices for the future. Right now, our choices are between bad and terrible. But if we do the best we can, it's going to be bad because it's 50% of the population exposed. But if we don't do anything, it will be terrible because it will be 70%.
And that, unfortunately, seems to be the direction we're going in right now.
That is kind of the unfortunate situation. I'm telling you, my mind was blown away last week or 2 weeks ago when President Trump came out saying that he was pulling out of the Paris Agreement. That is just craziness. At this moment in time, with so much scientific evidence, for this guy to say that we're going to have such a massive step backwards on this is just upsetting to the core. I'm telling you, I just get aggravated every time that I just talk about this because it just doesn't make any sense.
I would think that air conditioning is both a solution and a problem, because it can keep a person cool and they will not die, and one should keep an eye and make sure one's elderly relatives, etc., are in an air-cooled place. But also it uses a lot of electricity, which produces a lot of carbon and can make things worse. So it's a dangerous solution. Finally, I was talking with a friend from Pakistan and then with another person today who both said, yeah, it's global warming, but the reason we've reached 128 degrees recently, I think it was in May, a month ago, was they've cut down all the trees in Karachi. You know about this problem?
Yes, we know about that problem. The problem, another big problem that we had on the scientific community is the fact that we have been focusing too much on the emissions of greenhouse gases as the main driver of climate change. It turns out that climate change is also us cutting forests in the sense that now that forest, all of the carbon that is on those trees now is in the atmosphere, but you are also preventing those trees from sequestering that carbon. So climate change is the mixture of these two things, us producing CO2 like crazy and us cutting damaging ecosystems in such a way that now they cannot sequester that CO2. So, I mean, this is like a candle that we are burning from both ends, and this is why the things turn out so bad in those conditions when it's getting hot and unfortunately you don't have the trees to pull you down.
You said you were blown away by, looking at the results of the study. We have 1 minute left. What was the difference between what you thought you'd get and what you saw as results of your study?
To be honest with you, is that we had these different scenarios, and we had this scenario that is in which we do the best we can, and it's always the expectation that you find good results if we follow that pathway.
Yes.
For me, that was the shocking thing, is to find that even if we do the best we can, this is still going to be pretty bad. And to be honest with you, after a while, I was not surprised anymore because, again, you just had to see the damage that we had done to our planet so far.
On that wonderfully optimistic note, I think we have run out of time. Did you have any questions at all about this or wanted to add anything?
Well, I wonder if the air conditioning actually enables people to be in hotter climates and actually is part of the problem. The same way, protection from floods lets people build on coastlines. Is it actually a double-edged sword that we're promoting development in these hot climates where we shouldn't be living?
Absolutely, that's an excellent point. One of the things that air conditioners do, energy cannot be created nor destroyed. All what those air conditionings are doing is just transferring the heat from one place to another. So using so many air conditionings actually has been demonstrated that it makes the cities hotter.
Thank you.
So yes.
I have to cut you off there, but I get it. And thank you so much for your time, and thank you for coming in and staying with us for the second half of the program.
Thank you.
Thank you very much for having me.
You're welcome.
Bye-bye.
And that's POTUS 2017 for today. We're here each week at this hour, keeping watch on the Oval Office and pouring cold, hard facts on the overheated political rhetoric and sometimes the overheated planet. Brian Lehrer will be here next week. I'm Marty Goldenson. As the old-time radio guys Bob and Ray used to say, write if you get work and hang by your thumbs.